At the storytelling series, one of the listeners had asked you a question about burnout. And the first thing you said was family.
When I hate the word work-life balance, that doesn't work. That means like you need to lose one to get another. That's ridiculous. So you have to have it harmony. And I was also lucky. My wife is a librarian, so it's a little bit. But also I did my part, and what is good, my son is an intensivist.
Yes.
So that's really, I'm very proud of it. Many, if you don't show up at home, they don't want to go even to medicine, let alone to do pulmonary and critical care. But he does what we do up in Seattle, and I'm very proud of it. So, but I think that's critical. Putting the family first and understanding the value of that.
And that
feeds you back to your work too.
Yes. Welcome back to another episode of the Last Zebra podcast. I'm your host, Ezema. I'm here still at the American Thoracic Society conference, international conference in San Francisco. And these episodes are in conjunction with the ATS storytelling series. With that in mind, we have a very special guest, Dr. Ognjen Gajic. Welcome to the show.
Thank you so much, Ugo. It's a pleasure to be here.
Your story was very moving, and there was a lot to unpack there. I think we can't start without talking about rock and roll. You mentioned that you gave up rock and roll to be a medical doctor. When did you fall in love with rock and roll? And why was that such a pivotal part of your life growing up in Yugoslavia?
Yeah, so I just grew up with very talented crowd. They were just brilliant. So, and everyone is still in show business. Mm-hmm. And my mom made me play the piano. I didn't like it, but I had to do it. So I had some musical skills, and I knew how to play flute, and then took up saxophone later. So when they needed, 16, 17, when they needed someone with some polishing musical abilities, I got in. But it just was serendipity. The kids that I grew up with are incredibly talented.
You were in a band?
It was quite famous band in former Yugoslavia, and was kind of a punk rock, I guess. And it was, we wanted to change the world, to maybe prevent the war and things like that. So it was very popular.
And what instrument did you play at the time?
So I played keyboards, flute, and saxophone.
Wow.
And first three.
In your storytelling series, you mentioned that one of your teachers, and you speak a lot about mentorship, but one of your teachers had a significant impact on you. And you said, the way you worded it was, in 15 minutes, he had made medicine more attractive than rock and roll.
No, it
what did he do?
So the first 2 years, I really, I could memorize, so I did well, but I had other people signing up for me. I showed up for some absolutely mandatory labs, but everything else I was just studying, the preclinical stuff, anatomy, biochemistry, just in a van as we were touring, and would probably not finish. And then on a third year, there was introduction to clinical medicine. They call it propedeutics there. And Sasha Feigl, he was a professor, very, unusual man. He was like a, mountaineering, and was a boxer as a young man. He introduced dialysis to our country, described like Balkan nephropathy. So it was very special. And I was lucky to come into his group, and instead of a classroom like lecture, maybe there were 50, he turned himself into a old woman from somewhere in the mountains where he hikes, who speaks in a convoluted language, her some abdominal GYN problems, and we suddenly feel we have to figure out what's going on. And in 15 minutes, he made it such that, I got that, he combined the biology, psychology, and social stuff all into one, making it like a detective work that you have to do to help this. So it was just amazing. And within 6 months, I played on a third album, and I had to quit because I couldn't keep up. I started going to emergency room every fortnight from 6 p.m. to like midnight. Instead of getting out with friends, I would spend it in an emergency room. In a few months, they let me do everything. So on my third, fourth, fifth year of medical school, I was every fortnight in emergency room.
Wow.
15 minutes, one person.
It's crazy how we meet these people that have such a profound impact on our life and change the course of our lives.
Absolutely, yeah, it is. And that happened to me a few times.
I know your story is full of a few people that had such an impact. We wouldn't be remiss if we didn't talk about the war in Yugoslavia. And if I'm not mistaken, Yugoslavia is technically not the entity of Yugoslavia.
No, there are 6 countries.
Yeah, it's been separated into 6 separate countries.
Yeah.
And there was a war there, and the impact that had on you as an individual and your family and your education. You spoke about that. Can you tell us a little bit more about
so
that?
I was I just got surgical residency to start when the war broke up. And then suddenly, like, the city is in a siege by your own army in view, and it was, within a few days, everyone is drafted. There is your passport doesn't work, you cannot get out.
Wow.
I was lucky that my wife and 2 kids, we had like 2.5 and 1 year old, she was able to leave with the last civilian convoy they let out of this. And I wanted to stay, obviously, as a young doctor in my hometown to help at first. For the first year later, I wanted to get out, but I couldn't get out anymore. So
your family had left?
They left. They spent almost 3 years at our friends in a neighboring country in Croatia. We thought they're going to go for 3 months. They stayed 3 years until we reunited.
Wow. Once you were able to leave, well, let me ask you first. You mentioned surgery. How did you decide on surgery at the time?
So I wanted to do emergency medicine, but I couldn't get it. It was just not starting. So the second best for me that I thought, and there was some opening. My mom was a surgeon, so she retired. So I was able to get into the residency. But then the war broke up, so I just ended up assisting surgeons and putting chest tubes and amputations, things like that. And so when I came, eventually when we immigrated, I was to apply to surgery because that's what I started. So it was not, but I did realize back home in Bosnia that when I last time took the gloves off, I cried, noting that maybe that was the last time I'll be in a theater. Yeah, and that turned out to be true, but for the better.
You then came here, and part of your story is that you, of course, applied for surgery. Did you have to go back to medical school?
No, the school was, I just needed to pass the USMLE exams.
Okay, good.
I didn't need to go, but I needed to learn spoken language and also to have some money because we had kids, so we had to start working right away. We came as refugees, but within a month you have to start. So I tried bartending, I tried pizza delivery, but eventually I got a job as a nurse aide in a nursing home.
Right.
And it was really good because I learned the spoken language. I learned to care for the patients like directly. And it was very, very gratifying experience, actually. And it paid well at that time for what we needed. $8 an hour, and then if you do some overtime, it was time and a half. So 12 an hour, it was perfect for 95. So.
Wow. And you didn't match into surgery the first time?
So then I didn't, and then at that time, when you don't match, you get this to go to scramble. But that time they would send you the letter of that. And I remember looking at that letter that I didn't match and closing the door of the car over my finger. That was a shock. And I climbed up to the apartment building, and they were at that time my 4-year-old and 5-year-old they were just waiting for me to fix some train, and I realized what matters in life more. So I got over it easily, and then next day by noon you start calling programs who didn't match the applicants, and then the first few, I guess with the accent or whatever, they just hung up on me. And then a fourth program that I got on the phone, they asked what's my score, and I really had a good USMLE score, so I said there was like Thursday, come Saturday for interview.
And that was?
In Brooklyn, New York, New York Methodist Hospital.
Wow.
Then the rest is history. On the second year, I come to MICU, and it was like, I felt like home. I've done medicine twice, once in my language, once in English. I've, knew the procedures from surgery, and it was really a special place for me.
One of my favorite things that you mentioned was when you got that letter of rejection, really is, and it feels that way from the surgery, that you went home and your son was building a train, and immediately you realized, because the kids don't care, that you're having, you realize that there are things much more important in this moment. And at the storytelling series, one of the listeners had asked you a question about burnout. And the first thing you said was family.
Family, absolutely. I think, they call it work-life harmony. When I hate the word work-life balance, that doesn't work. That means like you need to lose one to get another. That's ridiculous. So you have to have it harmony. And I was also lucky. My wife is a librarian, so it's a little bit. So she took a lot of child, but also I did my part. And what is good, my son is an intensivist.
Yes.
So that's really, I'm very proud of it. If you don't show up at home, they don't want to go even to medicine, let alone to do pulmonary and critical care. But he does what we do up in Seattle, and I'm very proud of it. So, but I think that's critical. Putting the family first and understanding the value of that.
And that
feeds you back to your work too.
Yes.
I like that work. I don't know where I found it, and I don't know the reference, but work-life harmony.
Yeah, and I think that's such an important thing to remember, because it can feel at times that our work can be so overwhelming in terms of time requirement, personal investment. It can feel overwhelming, such that the real things that matter, and we have to always keep that into focus. But I agree with you. I love the harmony. They should feed into each other in such a way that you show up as your best version for both parts.
Yeah, absolutely.
One of your mentors, and I wrote it down here, is Dr. Ralph Hubmaier.
He was an icon in our field. He knew more about pulmonary physiology and ventilators than anyone else in the world at that time.
You mentioned he introduced you, or at least taught you about adding research to your clinical practice.
Yeah, so I was able to come to Mayo Clinic that had this critical care fellowship that just started, so it wasn't as competitive, and I was a chief resident, so I got in. It was wonderful, and I loved it. And then within 2 months, they offered me a hospitalist job.
Okay, for moonlighting?
No, to work.
Oh.
To quit the fellowship and because the hospitals are needed. And I come to him, I met him about around one patient in ICU, and we bonded about some ventilation equation. And then so I asked him what he thinks about it, because it was pretty lucrative. I had family, it was already, no financial issues and everything. You have a job at Mayo Clinic. What do you want? And he said, yeah, that's great. As long as you don't want to do any research or academics, it's going to be great. And the way how he said it, he kind of incited the fire. I finished the fellowship and did pulmonary upgrade to get 15 more months of research, the master's in clinical research, K award, and ended up mentoring a lot of other people, but just the way how he said that.
It felt like a challenge.
He incited the fire and it never fired. But also he was fabulous. There was, as he taught me, with the first paper, it was all red. Mm-hmm. Just everything was red, and you have to, it was a real drill. But he invested, obviously, and you have to invest time in your mentees, but I think he's proud of what I've done later.
I love that. You also mentioned about how one of his advice to you is you can do pulmonary, critical care, or academia. You can only choose two.
Pick two. That's really true. He also did the same. He did a lot of research and just critical care. It's very different. I loved my pulmonary patient and practice, but doing all three well, I don't think you can do it. It's just very difficult. So maybe for a few years, but if you're serious about academic and research, I think people usually drop one or the other.
Why critical care versus pulmonary?
So I just wanted to, since I started the emergency medicine, I was always into it. So that was, I did pulmonary more as a way to get an academic job, but I don't. It was, I always wanted to do
something much more
mostly critical care.
acute.
That's what my personality fits well, and I'm good at it.
Tell me about the Intensivist Manifesto. How did that come about?
So, the networking matters, and even the podcast and social media. That's the way of the future. So when the Twitter was good, somewhere like late before the COVID, critical care and emergency medicine, anesthesia, a lot of people from around the world, English-speaking world, were together, and it was really amazing place to share knowledge and everything. So I got to through hashtag and through some thoughts, I got to write a paper with 5 other people, some from Australia, US, UK, some even pediatric ICU doctors, and Matt Schuba, he's like the first author. He's amazing. He's from Cleveland, I think at Cleveland Clinic now. I've never met any one of them.
You've never met anyone?
No, but we went, to emphasize this tacit knowledge of less is more, and how you really be there, but don't just do something. Stand there. The idea of being very patient-centered and focused, and in a room, but not necessarily doing things all the time that could be harmful. And so we come up with this Zen intensivist idea, and then it turned out into a paper, and I think it's a very good way of explaining this concept to more junior generations. I think it fits well.
As an intensivist myself, one of my pillars of clinical practice is, and I say it all the time, and even yesterday with our prior guest, I mentioned a tincture of time.
Yeah, absolutely.
Often we don't give the patient enough time to tell us what they need. And I believe that if you allow enough time, the patient will tell you exactly what they need. So you just have to be patient.
And that's hard. It's hard to be
difficult.
Patient and not do things.
Exactly.
That takes more effort. I said, learning how to intubate, I guess 50 intubations with video laryngoscopy, you become pretty proficient. Mm-hmm. But learning who not to intubate, it takes you 20 years.
I was literally just telling someone this. I've become a better physician in the last, I'm 4 years out of fellowship.
Yeah.
So 4 years out of training. I've become a better physician in these last 4 years. Because that is really when you learn what not to do.
Yeah.
And that is so much more important than what to do. And training is critical because training teaches you what to do. And I don't know if there's probably not enough time. And that's maybe what actual being out there and practicing is for.
There's just a lot of pressures to do things, just from all sides. So it takes effort. Since we had work-life harmony, I often compare critical care to parenting.
Yes.
for both of them, less is more is very important. You can do a lot of damage. Also, you need to rescue, and sometimes there's a golden hour where you have to act, and you need some luck.
Yes.
And I think it's the parallel really goes well. But this idea that you have to, that less is more, and that too much parent, that you can do a lot of damage as a parent or as a critical care doctor, it's a very important concept that we realized over the decades.
One of the pivotal moments in your life was your experience with Yellow Jackets, where Yellow Jackets, and I'm not talking about a TV show, there's a TV show called Yellow Jackets, but where you were exposed to some Yellow Jackets, the bees, the hornets, and you went into anaphylactic shock. Can you recap that story? And
so not that I'm wanted to happen to anyone, but it did, just one of these days that was August, and one of the rare weekends that I'm neither working nor traveling nor I'm in somewhere in a wilderness. I'm like mowing the lawn, and there is a part of that I never went in, just can we call it prairie, but with a new lawnmower I got a chance, let's do it. And then I ran into a beehive, and I don't know, about 50 of these Yellow Jackets, they came after me like Nazi airplanes. They meant it. So, and I was just like a t-shirt and a short, so I rolled down the hill to get them off, and very soon I started feeling terrible, and I realized that I'll end up in emergency room, but I didn't have like a tongue swelling, and the good intensivist as I am, and I couldn't realize that you could get a shock without necessarily having an airway problem too quickly. And I said for my wife, let's not make a fuss, just you drive me there. And I take like a 10-second shower, put like the new t-shirt from Switzerland that my aunt sent me, knowing that I'm gonna end up, with people I know. And fortunately, there is a short drive. It's only like 7 minutes from where I live to, there's no traffic jam in Rochester, Minnesota. So I'm like trembling on the back of the seat, and I was able to get out in front of the emergency room, and I just say to my wife, okay, you can just park now. And then get out, and the last thing I remember, there was some like woman volunteer with a wheelchair. And then I pass out, and then the next thing, there's like a rubber smell, the mask, and there's, someone is poking in a groin. I hear like third liter, and then I also pass out, and then, a few minutes later, there's like boom, and then turn me, and boom, they're putting the defibrillator pads.
Yeah.
This is not good. But it was interesting, I could hear, absolutely, when your pressure is 60, you cannot see, it's all black, but you can hear. And I do that for life, so I knew exactly what they were doing. But what was interesting, I did not really think of dying or anything like that. There was a physician who held my hand through that. And every time as it was getting rougher, she would just squeeze her. And it was such a consoling, I don't know how to, it's just wonderful experience that I felt safe from that touch, and I questioned nothing. Although they're doing what I do every day, and I could, but there's no autonomy when this happens, I can tell you that. There's no shared decision making. You are right there too.
It's done.
It's done. But this hand holding, so I actually published, which was interesting, the ED physician, she recognized me because I was already attending, and I would come down to ED. So she was scared that I was going to die. So she did it for herself too. When we reconnected a few months later. So I wrote, it actually was published in a Bull Journal, and it's in several medical schools, at Hopkins and University of Arizona, a few other places, they have it like for medical students. But this really changed the way, or made me much more aware of what patients feel and can hear when they appear comatose, in shock and other things, and appear unconscious actually, or unresponsive. So I've got interest in several mentees who went to to study the psychological support. Because if you survive critical illness, the myopathy, that resolves. The organ failure, lung function gets after yes, you get like on room and near normal, little bit, DLCO down, but you can learn. But the PTSD and depression and these things, they are like, they're debilitating for life. So I'm much more conscious now how I approach the patient who is critically ill with dignity, with touch, with explaining what's going on, with trying not to use the words that could be misinterpreted, like nocebo. You probably know the book In Shock, so like Rana, which is kind of describes her journey to critical illness and all of that. So,
It's interesting to me because it's always been, it can be easy, especially when a patient has obviously lost that autonomy, and say for instance there's no family to communicate for them. It's easy in our line of work to forget the things that are meaningful.
Personhood.
And I think your story highlights that the touch and the hearing, so still talking to them.
Absolutely. What we also, as through this episode and my getting more interested in this humanizing ICU experience, we really try to use and implement, we call it Get to Know Me board, where above each bed there is something about that patient as a person, like what, the pets, the family, what movies he or she likes, what music, what sports. There's always something you actually bond with, and we feel that the patients and families love it. No one has
had any
problem with confidentiality or anything. They enjoy it and they feel that you care, and it really helps build trust. So it helps you, communicate with patient who is delirious, like with someone who is extubating. So because you start talking about something they know, and instead of delusion of being like, tortured or something, what they can feel, they understand what's going on if you say something familiar. And then building trust, it also helps obviously with end of life care, with shared decision making when things are not going well, because you build the trust. And I personally believe, and we are studying it now, one of my mentees, Dr. Sumaira Ahmed and Dr. Luda Karnotovska, they're working on studying its effects not only on patients and families, potentially preventing some of the psychological sequelae, but also on burnout. Because by bonding by knowing the patient as a person, I think it's actually very healthy for you. It takes away, by spending some extra time on getting to know the patient as a person, you win, and it takes your time away from like following urine sodium or some other ridiculous thing that we sometimes do when we spend time in a computer rather than with a patient. And I think that's very healthy for your brain too, because it's more meaningful. I mean, there's a lot of in critical care medicine, but you master the procedures, you master physiology, and within a few years after the fellowship, you are quite proficient. But the routine, and obviously research and education, that matters, but routine is there. But people, they're infinitely fun. There's so much to learn, like what, I've read 4 or 5 books now by my patients.
That they've recommended to you?
One of their, that they wrote.
That they wrote?
That they wrote,
wow.
2. One is really, really good. The woman writer, she was actually, I didn't know she was a real writer. The book is named Pointed with the Lips.
Pointed with the Lips.
Pointing with the Lips.
Pointing.
She's a Native American writer who describes a week in life of Reservoir Chick. That's like a subtitle. It's one of the really best books I've read about women, about alcoholism, and about Native Americans. It's just like an incredibly good book. And on that, favorite book, the son wrote book, and he wrote that it is by her. And the next day I read it. I mean, it was just, well, I would have never had a chance to get to something else. So it really feeds me as a human being. From a lot of our patients are very resilient and interesting, and you can learn a lot from that.
You mentioned you wrote something to the Blue Journal.
The hand, yeah. There was the hand is that experience from my critical illness, and I also had another one that was in critical care medicine, critical care exploration, the Get to Know Me board, and I have like 400 publications, but this one is my favorite because the patient is a senior author. The patient with disabilities who also kind of came to life through this, through the Get to Know Me board. And critically ill patients or patients with disabilities, they are easily forgotten or mistreated, or at least you don't understand their personhood. It's if you just focus on the numbers and how they look, and not, and some of them are absolutely incredible human beings.
You mentioned how family is very important to ease burnout and to build resilience. And you also at the storytelling series here, spoke about having purpose, autonomy, and mastery as core components or core parts of easing physician burnout. Talk to us a little bit more about each of those and how those applications help in making our day-to-day life a little easier and assists in getting the work-life harmony that we spoke about.
Yeah, so I think it came, I don't know the exact source, I think it came from some work on economists, on what motivates people, on psychologists and behavioral economics. But it's really for any work other than very simple, digging a ditch, the financial incentive is not what drives you. What drives people to do what you and I do is purpose. And obviously in medicine and in nursing or in critical care, there is very little to say. It's obviously the high purpose to make someone live better or die better. That's what we do. That's fantastic. But having that continuously, the mission, not being distracted by things which have peripheral to medicine. Medicine is full of it, but you have to focus on what actually matters, or really be relentlessly patient and family centered, and whatever doesn't go into the getting someone's life better or someone's dying better, if that's what it is you should just ignore. And then autonomy is very important for anyone who works. If you are confined and constrained, and you have to be programmed the way now things are by institution or by other ways, you will not flourish. It's just people need, if you allow enough autonomy, they give 3 times more than without it. So it's very important for any leader or an organization to appreciate that restricting autonomy cannot work. It will always backfire. And now in the age of programming and algorithms and AI, I tell, being the you program rather than being programmed. So we have to, because if people who, some the computer science folks who really don't understand what's going on, if they write the algorithms, it's not going to be good for anyone. We have to be there on the forefront of that. And then the third thing is really mastery. Why people play guitar on weekends, to get better and better and better. You just feel there is nothing so motivating than when you are doing something well. So I think it's very important to focus and do. That's why it's difficult to do academia, pulmonary and critical care well. You need to focus on some, and just being better and better in anything you do. That's the most gratifying aspect. So it's kind of mastery. So I think these three do motivate us, and I think it helps prevent burnout and have long and fruitful careers.
Your son is an intensivist, as you said, and you feel like you did it right.
I'm very proud of it.
You're very proud of it. When he first decided to go to medical school, and along the way, internal medicine, along the way, pulmonary critical care, what did that, I know you're proud of it, but what was that sense of pride like?
I mean, first, it was important that we never pushed him to do any of that, but I think by looking how I enjoy what I'm doing, and I guess I was able to be there for the kids, so it wasn't that I was always somewhere else, and then you don't want to do the work that you're never home, so I think by showing up and showing the joy, but maybe emulating this work-life harmony, I think that, but also his teachers and others, it's like it takes a village, so I cannot take the full credit, on the family, but I'm proud of it because a lot of children of people who are doctors, they don't go into medicine because of the fact that the parents are never home sometimes. So.
Outside of medicine, what do you enjoy to do?
I enjoy nature a lot. So we have a cabin up close to Canadian border, like among these 10,000 lakes in Minnesota.
No yellow jackets.
No, not there. But over there, could it happen up there, I would not come out. But have the EpiPen. We do a lot of canoeing, boundary waters, canoeing, a lot of hiking, so a lot of outdoors. Have a dog, very athletic. Now grandchildren, have 3, 2 in Seattle, 1 in Denver. So spending time with them, that's special. I took up tennis in my 40s and I enjoy it immensely. So I try to play tennis a couple of times a week.
Yeah.
I don't know, those are the things.
Have you
play music a little bit, like tenor recorder,
I was about to ask you, do you still get to play piano?
Sometimes, but mostly the flute and saxophone is difficult for the mouthing, but the fingering you remember for life once you learn. So the tenor recorder has a pretty good, especially wooden one, it's a beautiful sound, but it's easier to play. So I play that by the fire up north.
Eastern Europe is going through a lot of changes right now. I was curious to ask you about, since you've left, have you been able to go back?
Yeah, I have. I was fortunate to go back and actually help a lot with establishing medical intensive care units in my home country, in all of the country of former Yugoslavia, and then that interest also turned into what we call CERTAIN, the program that we help establish and teach and improve quality of critical care in many places around the world where it's just the beginning. In many places, just anesthesiologists who are like busy in the operating room. So people who are critically in need of medical critical care, they often don't get. And COVID was like a wake-up call for everyone. So we have done we have this mostly virtual program with virtual simulation training, combining ABCDs like ATLS approach and to resuscitation with plan by systems, like kind of how we do rounds in critical care, going systematically to share the plan with the whole team, and then humanizing aspects to get to know me more. So we have that as a complete workflow, which we call CERTAIN, checklist for early recognition and treatment of critical illness. And we published a study, one of the largest QI studies internationally on really 5 continents, and which showed improvement in processes and quality of care, but also in mortality and length of stay. And we extended this program now to more than 2,000 physicians over like 30 countries. And we helped, even with, anesthesiologists facing the civilians facing war trauma in Ukraine, through, people who have we're having a program in Ghana now. We have a program in Cambodia. We have some programs in China, in India. So we're working to extend this focused, efficient, patient and family-centered critical care around the world, mostly through virtual simulation, virtual kind of podcasting, or getting together with a longitudinal program. It's not like one time. So we adopt the hospital for a full year, like 40, 50 people, some nurses, some physicians, to have this learning community. And the impact is quite remarkable. Like in my home country, there are 2 ICUs who are really flourishing, who started from almost nothing to ECMO programs and regional place for plasmapheresis and everything, just slowly working. We call it, I guess, there's many publications now on it, but it's kind of teleeducation. It's not telemedicine. You're not like treating patients. It's different from EICU. It's basically you are doing tele-quality improvements, so virtual work, but longitudinally for a full year, where you get back and forth, you bond with people, and then they stay within the community. So we have on WhatsApp, on Viber, we have groups where we interact with these, so with each and these applications now they can automatically translate. So the people are talking Ukrainian and we answer English and
go back and
forth for clinical questions, for QI questions, for burnout questions, things like that. So it's very exciting time to do that stuff.
That's wonderful, wonderful to hear, especially where global health is concerned. And finally, if I was to ask you to introduce yourself, how would you introduce yourself? How would you describe yourself in totality?
Oh boy. I don't know. I'm intensivist. I'm a father and a grandfather and a husband, and former musician. There's a Wikipedia page, but not because of my medical career, because of the band.
Of the rock and roll
so
band.
They have each one. So even that I had. But so an ex rock musician.
Yeah.
I don't know. I mean, it's been a privileged life. It's a really wonderful life that I was able to live, and I think education matters. And if you can, get educated, have that privilege, and then use it wisely, there's no limit.
Dr. Gajic, it's a tremendous pleasure.
Thank you so much.